thanks everyone for coming to this session. I was told before I came through here that we're double the audience that the politicians have got, but that's either a symptom of the seriousness with which science should be treated or a symptom of the lack of seriousness with which we should treat our politics just now. The two guests I have today are brilliant and brave gentlemen who have stood up for truth and evidence in science for the last, well, in your case, I don't know so much about Michael, we'll find out, but you for some 22 years. I'm going to ask them both to explain how they got involved in the whole issue of gender v sex. I'll start first, and then I'll ask questions and drill down to each of their areas of expertise. So, Michael Biggs, I would love you to explain how you got dragged onto this battlefield.
Sure, yes. I suppose the short version is that in our master's course at the University of Oxford, for Masters of Sociology, we give some puzzles to the students after that when they're almost finished their course. And it's the idea that they would just come up with sociological explanations for phenomena to use the theories that they've learned. And so one of the puzzles that I gave in 2016, I believe it was why are there so many more trans kids? At that point, I'd just seen an article in The Guardian out the corner of my eye. I had no particular view on it. And we had, I thought, what a good discussion, including some ideas about social contagion from a student whose boyfriend was a teacher and was saying, oh, lots of kids are coming out in the friendship groups. And then immediately after the class, a graduate student came to me and said, things were said during that seminar which you should not have allowed to be said. And I was very upset. Well, first of all, I'd been very pro-trans and very involved with trans movement in Boston. So I thought 20 years ago, so 20 years before, almost, what, 10 years before? Almost 20 years before. So I thought, wait a second, I was a trans ally before you were born, practically. But then I also thought, hold on a second, that's not the right, there's something wrong, that's not the usual thing. Usually you disagree in a seminar. You say, no, that's wrong, and you give evidence or you give reasons. You don't come up to the teacher afterwards and say you should stop things being taught. And then she was American, needless to say. But then two German students also emailed me and said things were, particularly the use of the word trend. So I said, why is there an increasing trend of kids identifying as trans? Well, that is a word, that's a tricky word, that's the wrong word to use.
What was the wrong word?
Trend.
Trend.
You should, and I said, but wait a second, trend is just a curve going up or down, right? There's not a value judgment. No, that could be problematic, that word. So they said, basically the thing was you need to educate yourself about the subject. So I educated myself.
It's really interesting. I hadn't heard that story. I don't know. I meant to say that if you haven't read Michael's recent paper, which explores the whole emergence of the famous Dutch protocol, which lies at the heart of all gender identity or gender-affirming therapy and treatment, then you definitely should. Where would they find it?
So it's in you can just Google it. It's just Google Michael Biggs Dutch protocol, and it's in the Journal of Marital and Sex and Marital Therapy, and it's free to access, so you don't have to have a university account.
Great. And did you find, I find with everybody I talk to, that the stuff that triggers their sense that they've stepped through into a different kind of world that doesn't operate by the same rules as normal science is when they encounter something that Michael has encountered where you're told that actually you can't say that. When is it that you felt the same sort of triggering of your antennae that scientifically you weren't allowed to ask questions?
So when I was at the Portman, which is physically next door to the Tavistock, as part of my experience, I wanted to gain experience in all sorts. So I was attached to GIDS, the child thing at the Tavi, for a couple of years. And I also went on little day trips to Charing Cross so I could sit in on their clinics and see how they were doing it. So I've had a completely 360-degree experience. So I know how things happen in these places. And the GIDS thing was completely eye-opening because you had 3-year-olds coming in and you had, I coined the term transsexogenic mother, which I now think has been superseded by this wonderful term transhausen by proxy.
Transhausen by proxy.
And these days I see very sensible parents, sort of parents who go to Bayswater and very concerned about their children. But in GIDS, I saw these parents who, many of them wanted actually a son rather than a daughter, whatever it is, or other way around. And there'd been 3-year-olds coming in, and the parents would say, oh, well, you know, Johnny's never liked being a boy, so we've changed his name, we've got him a wig. And I was thinking, this is mad. And with the GIDS at the time, so 20 years ago, GIDS at the time, the multidisciplinary team involved mermaids. And it was just a transing factory. And it had a very enigmatic person running it. And I remember saying to him, well, this is madness. What we're doing is mad. These are children. These are 3-year-olds. They don't want this to be anything. And the enigmatic leader said, well, is it any more mad than if they were gay? And for me, that was the point where I thought, this is complete madness. And for me, I've gone from thinking, well, the people are mad, to thinking, well, actually, we're mad. So the madness is in society rather than the individual. The individual is a nodal point, and they may have got to that point for whatever reason, but the madness is within us, not us, them, society, because we're going along with this madness. And I have to shut up now.
We've done
It's
so many interviews together now that you can tell I'm about to ask you something. If you can briefly, and then I'll ask Michael, because people might not know, the difference between, if you like, the model of the way in which the ideas are discussed in gender identity science and any other science or medical science. In other words, this sort of starting with a...
There's no science.
Okay, but they would think it was a science. I did the quotation mark.
So if you have any medical problem, if you have an ingrowing toenail, there'll be an intervention where there's been lots of evidence and lots of people doing boring studies on ingrowing toenails, and there'll be some evidence to show that the intervention you have is probably going to be helpful. So the only branch of medicine where there's no evidence is in physical gender treatments, hormones and surgery. And I was in Charing Cross once, and I said, why do you not do any follow-up studies? And they said, because we're releasing, it's like caterpillars becoming butterflies, we release them into the world. And I thought, oh. And then in GIDS, there's no follow-up studies. And it was quite interesting because one of the criticisms of the CAS review to the Tavistock was there's no data, there's no follow-up. And the Tavistock is great at keeping no data. So when I was at the Tavistock in Portman, I was there for 12 years, patient files would be paper thin because you just write patient attended, no risk. And they don't like writing anything. It's all in your head. Anyway, so the critique of the Tavistock, well, there's no data, there's no outcome studies, what's the evidence? When I was having my midlife crisis in Australia, I had a research team and we created an outcome measuring tool. So you can collect data and it measures, it's called the GPRSQ. And it measures gender dysphoria and it measures change. It doesn't measure how male or female you are, it just measures how happy you are with your gender, whatever that is, and how stable you are. And so we invented the wheel, and I've written to the chief executive of the Tavistock a million times, as people who follow me on Twitter know, and said, look, we know you need to collect data. I've invented the wheel. It's free. It takes about 50 minutes to use. You're welcome to use it. And they never responded. I thought, what, if the criticism is that you're not collecting data, and someone says, I've got something you can collect data with, why would they not want to collect data?
It's almost as if they don't want to know the results.
The only place where they have collected data was the John Hopkins, who invented sex changes, and then their data was so terrible, they closed it down.
Exactly. Michael, could you, I mean, I know it's a long and complex sort of study that you've done, uncovering some incredible discoveries about how unevidenced the Dutch protocol is. But just for those who haven't read the paper, if you could sort of sum up, if you like, the biography of the Dutch protocol, where it came from, and how little evidence was backing it, and where it now is. And I think this works. But try that one.
Here?
No, it's not.
No, okay. So the Dutch protocol was invented the main protagonist was Peggy Cohen-Kettenis, who is a psychiatrist, and she was started in Utrecht, and there's also an endocrinologist by the name of Henrietta Delmar van der Waal, and she was the first one. She was working actually with puberty blockers, well, the gonadotropin-releasing hormone agonists for precocious puberty, and she then gave, as an experiment, to a girl who was gender dysphoric. And Peggy Cohen-Kenters was amazed when the girl came into the gender clinic later and thought, she looks really like a boy. So this is a magic pill. And Peggy Cohen-Kenters was already very keen on transitioning very young, much younger. And in fact, one of the reasons why I got more into this of medicine, scrutinizing the medicine, is that I read some of Peggy Cohen-Kenters' articles from the 1990s, and transitioning these young teenagers at that point. And she would, she described one girl, for example. She said the parents brought her in because she was wearing a tight T-shirt to conceal her breasts. She was 17 years old, and she basically had light football, and she had not dated in high school in her last year. She hadn't gone on any dates, and so of course then I gave her it was just before puberty blockers, so it was progestin, I think, to stop her periods, and then we got the double mastectomy and everything was great. And obviously she was, needless to say, she turned out to be homosexual. She fancied women. So that was the kind of thing you read and you think, this is crazy. How can anybody be thinking that this is not just just an obvious sort of basic, lesbian who was not very feminine? And yet Peggy Cohen-Kenters really believed that this is the kind of thing to be kind. The crucial thing is with puberty blockers is that you can, thank you, Sharina. The crucial thing with puberty blockers is, of course, the idea is it's a magic potion, and that once you can make people actually change sex. And so there's this kind of fantasy, and obviously they were being kind, and they thought these people are going to have to change sex eventually, so it's much better to start it earlier, and then puberty blockers followed by cross-sex hormones will achieve the superficial resemblance, and they always focus on the superficial things like height and how you appear. They don't focus on sexual function or fertility or any of these other things. It's like how good you look in the role, and of course they do have people end up, if they suppress puberty early enough, do look much more, resemble the opposite sex more than could be done without puberty blockers. So originally it was done for very, very few kids. I mean, it's basically one a year. And then suddenly the numbers just keep increasing, and they just roll out, the same, they just keep rolling out the puberty blockers. There was never any trial, any randomized clinical trial that was done. So when they used, for example, for men, the same drugs they used for men for prostate cancer, of course they had a randomized control trial to make sure it was better than the previous treatment. But for when it was genital dysphoria, at first it was so few kids, you couldn't have a randomized control trial. And then there were so many, they just said, well, we know this is good, and we couldn't deprive the poor kids of...
And what happened to the original kid, which would be 1997 or 1994? P, I think the girl's name was.
Now the initials are FG, but yes.
Oh, right.
So yes, and that was another reason why I got into this, is that when I read the case study of the follow-up when she was 30, it said that she was ashamed of her genitals and she couldn't have a romantic relationship because she was so ashamed of her genitals. And they reported this as, this is great. This is a person who's doing well. And I thought, again, you read this and you think, but this is not a person doing well at all. And that she would actually fit the criteria for gender dysphoria, being ashamed of your genitals. But fortunately, she is doing better now. There's a follow-up. She's now in her 40s. This is the first child who ever went through that. But she says it was he says it was life-changing for him now. But he also says you really need very thorough assessments of children. So even there, I think you can sense a kind of maybe some reservations there. But of course, there's no point. I mean, I wouldn't want him to regret what he'd gone through, because at this point, that's their life. And so, and I think there's not only the problem of follow-up, but there's also the problem of doctors obviously don't want to find that they've made a mistake, but also the patients themselves, if they've gone through a process. We don't want them to feel that they've made the wrong decision. So everything is kind of loaded towards, saying this was the right thing.
And how did puberty blockers, did you see over your period in sort of engagement with gender identity clinics, the rise and triumph of puberty blockers?
Yeah, I hate the term puberty blockers. So in reality, you're castrating a child chemically. So puberty blockers is so sanitized, and it's like the amazing talk that Richie gave earlier and how we sanitize language. So the reality is you get a child who, for whatever reason, is confused, doesn't feel good about their body, and then is sucked into this trajectory of a gender clinic. And the idea is that you save them from the awful trauma of going through puberty by chemically castrating them. Okay, so you chemically castrate this child. if you didn't chemically castrate them, they might go through puberty and actually feel more okay about their body because actually, oh, I really am a male after all because I've got a male body or I've developed like a female or whatever. But no, so you castrate them so they don't go through puberty. They become this sort of androgynous eunuch who hasn't gone through puberty. And then we know that almost 100% of children who have chemical castration and go through this process then go on to cross-sex hormones, and then a large proportion will have surgery. And in reality, if you don't go through puberty, if you've stopped it by castrating them chemically, then you don't, in blunt terms, your penis stays very small, it doesn't grow very big. And then if you were to have surgery, if you have a penile inversion, you don't really have a very big cavity for a neo-vagina. So a child who's never gone through puberty, who has puberty blockers, then has sex change, has a pretty much non-functioning neo-vagina, and also there's a high chance they will never have an orgasm. If they've never had an orgasm before puberty blockers, chances are you're not going to have an orgasm afterwards. So no child can give consent. They all, it's all very well them saying I want to be a man, but they can't give informed consent to never have an orgasm, never have any sexual functioning, never have a neo-vagina that they can have sex with. And this is what you don't hear of. And I think that's awful.
Yeah, absolutely. I always think in this whole area, my golden rule now is it's always worse than you thought it was. And so, for example, when I read your paper, Michael, I suppose the golden rule, it's always worse, is why, for example, mermaids can end up having a paedophile apologist as a trustee. Even I, in my worst dreams, thought there's no way that could possibly be true. So it's always worse than you think it is. And in your paper, you revealed the fate of one of the kids who suffered exactly the problem that Az was talking about.
Yes, so really the only evidence, positive evidence for the use of puberty blockers came from a study that was published in 2014, where they took the first 70 kids who had been on puberty blockers, and they say they're doing very well now. This is just in the honeymoon period after surgery, but they do, and they have measurements of about 30 or 40 of the 70, but they say some of them were lost to follow up and so on, but one of them died after necrotizing fasciitis from their neo-vagina. And that's also that's another, apart from the case study of FG, it was also that I read, but I said, but wait, one of them died. And that's a big deal. It's like, but apart from that, how was the play, Mrs. Lincoln? So what I found in my article, and the first time it's been published, this fact has been published, that the reason why the kid died is because precisely the problem that Az pointed out, that because the penis was too small, they have to use a part of the intestine. That means they have to cut the intestine out, cut a portion out and then sew it back together again. The sewing it back together again wasn't done properly, and there was a bacterial infection that spread and killed the kid within 18 years old, within 72 hours. And so it wasn't just that the kid died, so you have effectively an over 1% fatality rate for this experimental treatment, but they died not just as an accident, like they got a hospital-borne infection or something, but they actually died as a sort of indirect consequence of the puberty suppression, which I think completely discredits that trial.
And one of the other things, I read your paper, and again, it's sort of, I always keep thinking, God, I'm supposed to be this bigot that thinks the very worst of the trans movement and the very worst of gender identity care or whatever. But I read your paper and thought, even I thought that puberty blockers might help gender dysphoria. I mean, it's not in and of itself a reason for doing it, but I thought, well, maybe it does help some kids with the gender dysphoria. But it was astonishing that, partly through your pressure and other people's pressure, when the Tavistock published its one follow-up study, it didn't reveal that gender dysphoria was helped. Can you explain, I'll get you both to explain why you think puberty blockers don't help with gender dysphoria.
I think it's really the reason that as pointed out, actually having your puberty halted, and particularly not going through the same sort of, you're no longer going through the same stages as your peers, actually means that you don't, you fit in less with them because now they're going through puberty and you're not. You're sort of stuck in this almost like Peter Pan sort of situation. Yeah, and also, there are also consequences. I mean, the body, puberty is the natural thing is that we should be going through. Those are the things that our body should be doing, and that's the thing that also helps us form, mature emotional and cognitive development. And so, in some ways, I would say it was surprising that anybody think that chemical castration would be a good thing for children. I mean, obviously, if you've got prostate cancer and you're going to die unless you stop the testosterone feeding the cancer, then of course you're going to do that, and that makes sense. And also your body is now fully formed, you're an old man. But the idea that children, that this would be a good therapy for children was always a priority, and extremely, all the common sense, let alone sort of medical knowledge should have told you, it's very unlikely that this would have been a useful way of treatment.
Take that, Mike. Thank you. In addition to telling me why you think gender dysphoria isn't helped by that, by puberty blockers, I also wanted you to touch on the deep, dark subject of paedophilia. So, I'm opening it up for debate. I don't think, as some people have argued, that it's a giant paedophile conspiracy to keep kids at the infant stage and unsexual. But I do think there's something in the Peter Pan sort of desire among parents to keep their children as children. That I wonder, well, I'm opening up for debate. Are some parents who are suffering from, trans by proxy or whatever, transhousing by proxy, is it in psychiatry something that is understood that parents have a problem with, at the best of times, with their children growing up and becoming sexual adults? And is that something at the heart of one of the reasons why they want their kids to go on puberty blockers? How's that for a lot to answer?
I don't think so.
I think you're wrong.
Rather than it being wanting their children to be asexual, I went through all the data of my patients, and if you compare the contact I had with patients compared to the gender clinics, they see them once every 6 months. They might see them 5 times before they let them go. I was seeing patients every week, and some of my patients I saw every week for 10 years. So I knew these patients really well. I knew them better than most other people knew them. And I went through all the data at the end, and I was going through looking at various factors. There was a large representation of people who'd been born as replacement babies. And I'm not saying this is causal. I'm saying that there's obviously lots of inputs. But there was an over-representation of people who, their parents who'd lost a child and then they'd suddenly got pregnant again, and almost through unconscious communication, this child became a surrogate for the lost idealized child. And so there's a bit of that going on. No, it's not causal, but it was massively represented in my sample. I wanted to comment on something you were talking about before.
Gender dysphoria and how it's not helped.
So in the GIDS clinic, so you had various reasons as to why the patients came there, but then in the institution, and you've got to remember that the GIDS clinic was set up at the Tavistock, which has decades of institutional homophobia. I mean, I've seen it firsthand. I've witnessed discussions in clinical groups. I've seen, huge evidence of it. They've never knowingly employed any therapist who's gay, and they've told trainees that they can't be given consultant posts because they're gay. That's fact. And so, when they're looking through the data for these children, one of the reasons why they felt that they should be the other sex is because they were same-sex attracted. And that was a reason why this person should be the other sex, because they were healing them of their sexuality. And so you had whatever reasons the child came there, combined with this facilitation by this quite homophobic institution, which is providing the service. Whereas if you consider that my intervention was a therapeutic one, What I didn't notice was any therapy going on. So the wide public out there think that in order to have a sex change, let's call it, I always say sex change because you can't really change sex, you have to have lots of therapy. You don't have any therapy whatsoever. The therapy I was providing at the Pullman Clinic was the only therapy available in the country, and that was for people who wanted to go there. I certainly wasn't seeing everyone. So most people just have to go see a psychiatrist. They say, do you want this? Yes. Are you sure? Yes. Okay. That's the psychological component. It's a tick box. I literally saw them ticking boxes. There's no in-depth conversation. And so there's no therapy. There's a brief tick box exercise. But in the therapy that I was giving, I was thinking, why are they doing that in kids? And when you had a child saying, oh, I don't want to be a boy, I want to be a girl, no one was saying, what is a boy? What is a girl? Whereas all my highfalutin, fancy pants, smarty pants therapy was basically me saying, what do you mean you're a man? What do you mean you're a woman? Tell me. And I wasn't saying, no, you're not. I was saying, help me understand. How did you get to this conclusion? And it would usually be some sort of semi-autistic, sort of faulty data processing that got them there. A bit like my maths A-level, I ended up over there rather than there. And by having just a normal conversation, exploring with them how they got there, it sort of sorted itself out. And in my population sample, at the end of the 12 years I looked at my population sample, less than 2% went on to have physical sex changes, because they were all fine.
Really interesting. I don't know. How are we for time? How are we for time? What's the time? I was going to get some question and answers, so...
Thank you. This is a question for Dr. Hakeem. I'm a trans widow. You touched on the subject of fraud and a second word.
Deception.
And deception. Can you please tell me a little bit about what you discovered in those studies? Thank you.
Very brief. So I'll give you one example. I had a patient who was a very early sex changer, and not really for any fault of their own. They'd grown up in a country and a society in the 60s where you couldn't be gay, and their mother forced them to have a sex change. Anyway, so this person spent the next 50 years of their life as a trans female, but they had marriages that lasted decades, and partner never knew. And I suppose that level of fraud and deception, but it's sort of understandable because they couldn't. Yeah. So there's that level, but there's some of it is quite subtle, some of it is quite non-subtle. So the deceptive thing, and societally, where we are now silenced into having an awareness of reality. So we all feel robbed of reality when we're having to collude with the idea that somebody with a penis is a woman. So that's that level of deception, which is not even that deceptive. So that's what I meant.
Thank you. It's a question for Michael and for Az, really. What do you think of the ethics and the practicalities of actually doing randomized controlled trials of puberty blockers?
Good question. Really good question.
It's ethical in the sense, I think, that there is enough demand now that in some sense it's much better to have robust evidence finally, whether the evidence is favourable or unfavourable. So I think it's worth, and there are certainly a lot of children who have been told and parents who have been told that these are life-saving medications. And so I think that is ethical. I think it is practical. Obviously, it can't be blind, as long as you can stop the people in the control arm from actually going on to gender GP and getting hormones that way. So I think it will be tough. It would be tough, but it's certainly better to have a sort of a flawed or imperfect clinical trial than to keep going after a quarter of a century with no clinical trial at all.
I would disagree, because I don't think that any child can give informed consent to be chemically castrated.
Hi, regarding chemical castration, it's Aldur from LGB in Iceland.
Hello. So the Eurovision Song Contest here.
Right, with chemical castration, very often I find myself having to jump through a hurdle when I'm having a debate or discussion with people. Can you explain to us in short terms what is the difference between giving puberty blockers to a child with dysphoria, or someone going through precocious puberty. People who are given those medication for precocious puberty, are they coming out of it castrated?
I think that's quite easy, that one.
Yeah, so precocious puberty is for very, very abnormally early puberty, and then the puberty blockers are stopped at a normal age, so they go through the normal puberty. I should say that even precocious puberty, there is a critique that is done of that, particularly, for example, the only rationale for precocious puberty is height. So in other words, if you go through puberty very, very early, it means that you end up shorter than you might be otherwise. And so the argument is that you need to intervene early in order to make sure the person's not too short. And there are questions about whether there are also consequences, for example, intellectual. I mean, there are some quite frightening studies of precocious puberty where the kids lose quite a lot of IQ points, even though they're very small samples. But it's like, even for precocious puberty, I think the sort of jury is still out whether it's good. But even if it was really good for precocious puberty, that is different between stopping a very abnormally young child going through puberty. You know, you just pause till they go through the normal age puberty. And that's different from the case we're talking about with gender dysphoria, where the child is never going through their own natal puberty. And they'll go through a sort of a pseudo-puberty with the sort of opposite sex hormones, which obviously are not meant for their body, much, much later at the age of 16. So I think the two are completely incommensurable. But you're certainly right in pointing out that's one of the justifications, because they say, oh, we use these on kids anyway. And and of course they are licensed for precocious puberty, but they're not. The drugs are not licensed for gender dysphoria.
Thank you.
Any other questions?
Yeah, it's a correction actually. It's about the Tavistock, which I know quite a bit about because my mother worked there for 50 years. And I just want to say that the current joint head of the child psychotherapy discipline is a gay man, and there's also a previous head of the child psychotherapy discipline who's a lesbian woman who's also in a relationship with another Tavistock clinician. So I just wanted, for the record really, I just wanted to say that. Not the GIDS, the Tavistock, which is separate.
Okay, thanks.
In the Tavistock, there are divisions. There's the child, adolescent, child and family, adult department, and Portman. I'm specifically talking about the adult department, GIDS, and the Portman. So the adult department will not allow homosexuals to train or work as therapists, nor the Portman and the GIDS or GIDS. The child and family are very different, and it's almost like oceans apart, and there's no communication between each department.
Hello, yeah. I wanted to ask both panellists. You mentioned defective evidence and lack of follow-up and so on. I've recently, just out of interest, been going through journal articles about essentially early childhood education and encouraging kids to think about being gender dysfunctional. And I checked out the references, which should have been done by a peer reviewer, and they turned out all to be wrong. And I wonder if you reside any confidence in the professional journals on which you are supposed to depend for the practice of your discipline. And if not, whether you should not both make that known to the editors of any of the journals that are publishing articles which you believe are defective or misleading. I can give you the names of articles and of editors who are guilty in that respect. Are you aware of any?
Thank you. I was going to widen that question out, if you don't mind, to ask both of the panelists. The good thing, if you like, about this debate is it reminds the public that science is a human project. There's a sort of an assumption in the public that scientists get together and it peer-reviewed as an absolute stamp of authority, and that scientists don't make mistakes. And this is a perfect example of where everything has... And obviously, standards are normally much better, but they're not perfect. It's just that the standards were absolutely atrocious in this field.
To answer your question, I don't think anybody will listen to us for a start. And I think a lot of us have lost faith in the medical colleges, which have all seemed to have been corrupted by gender ideology. The fact that you've got the Royal Society of Medicine, the Royal College of Psychiatrists who've all gone gender woo-woo. Just a brief plug. So I'm part of CANSAG, I know it's not a very snappy name, it wasn't my choice, I wish we could call it something else, but we're a group of clinicians of various disciplines who are very concerned with how gender dysphoria is treated physically rather than psychologically. So we have got a stand. It took us a million emails to work out how to do a leaflet, but we've got leaflets. So we've got a stand. Please sign up. And yeah. So our group had a meeting with the Royal College of Psychiatrists last year, or was it this year? I can't remember. And it was a bit like talking to statues. The president started off by saying, "Can we just get it clear? Everyone here agrees that sex reassignment is a good thing." We thought, well, that wasn't really on our agenda. We wanted to talk about other things, really. And then everything we said, they came out with sort of mantras, a bit like the crowd outside. They've only got 2 sentences. So it wasn't very fruitful. And whenever we've tried to engage with the Royal College of Psychiatrists, it's deaf ears. They're completely captured by Stonewall. So those of us who feel we are still residing in reality and science and biology feel a bit let down by the organisations and institutions who really should know better.
I'll just say that, I have written, there have been a lot of very bad articles written, particularly, for example, by Jack Turbin. And, I've written critiques, of those articles which have not, in most cases, have not been published by the journal, which is unusual because normally journals would publish a serious critique and then allow the author to respond in turn. So I think it's partly just a matter of plugging away, and it is 10 times as hard to publish something critical as it would be to publish something affirming, if you will. But I think it's really important for those of us who can to keep sort of chipping away at this huge wall of nonsense.
And I'll give you in a second. It's worth writing letters. It definitely is. It's a pain in the bum, and it takes ages, and they won't get. Yeah, definitely write them.
I was going to say, the good news is that nobody reads academic articles. So when I was in the wilderness for 20 years, before I was on Twitter, I was writing loads of academic articles and journals about my work. The only person that read them was me. So nobody knew what I was doing. I was a little abyss in my little world. It was only when I went on Twitter that people actually knew what I was doing, and when I wrote a book that the sort of normal people could read. So I wouldn't worry too much about the academic stuff because no one reads it.
Okay, it's me, I think.
Yeah.
So you mentioned Peggy Cohen-Kettenis before. I wondered what you thought the reason was that there isn't a wider outcry over the homophobia, because obviously a fishy organisation sent a video to my school about 15 years ago and I noticed it immediately. Maybe not necessarily in psychology, but how come wider society doesn't actually immediately see what's going on?
I'll pass over to Michael, but of course, this is exactly the reason that the gay movement was taken over, because then the accusation of homophobia strikes the public as bizarre. How can Stonewall be homophobic, is the immediate response.
Maybe someone from the Netherlands would be better to give the wider sort of cultural context, but I've talked to a few Dutch people and they say that there is something very sort of conformist, even though it seems to be a very sort of sexually liberated culture. There's also a degree of conformity there, and I think this was making people look more normal, look like they should be, in a way that maybe having a very gender non-conforming homosexual kid or adult would not be. So I think I think they were trying, there was obviously good motivations. In some sense they weren't malevolent motivations, but certainly, I don't understand why they could not see this, or at least give the option and just say to the kid, for example, look, you could be, a transsexual, a trans man, heterosexual, or you could be a butch lesbian, and there are 2 options here. The two older role models who come and talk to you about their lives, and you make a choice. But it was always just, no, you must be a trans man, and they never seemed to give the option of, well, you could also just be a gender non-conforming person in your own sex. To me, it still puzzles me as to why they didn't at least open that up as an alternative route.
I think we've got to round up, but I wanted to give an example of how poor the science was that I've only just discovered. It's always worse than you think it is. There's a book on the brain. No, there's another book by another person, not you, Az, And and it's about the brain and brain science by Dick, strangely and ironically named Dick Schwab, who's a Dutch scientist and very eminent. And he did an experiment with fMRI scans. He said that it's the only proof he gives that there is such a thing as the transgendered brain. And he did, I think it was only 6 people. He put an fMRI scan machine around their brains, and these were trans women, and i.e. blokes who were probably gay, and they blew male pheromones over their faces, and their brains reacted, right? And amazingly, these male-bodied people who were supposedly trans women, their brains lit up. Now, I would say, well, that proves they're fucking gay. But no, he writes an essay in this book on brain science that says that proves they were transgender. And so, I mean, I think that's the part of the problem that we face, is that if you start with the assumption, or 6 assumptions, that the transgender brain exists, you will find, you'll devise an experiment that will prove what you always wanted to see. And you can comment on that. How is our science skewed?
That's bad science, isn't it? You know, you just forget the physical interventions, forget castrating children, talk to them, say, what on earth do you mean you're a boy or a girl? What do you mean? What's wrong about being a boy? What's wrong about being a girl? And just bring it back to basics and try and work out with them how they got to answer A rather than B. Don't chop their balls off.
You heard it here first. Do not chop balls off. Or breasts. How bad the science is, and how will we get out of that hole?
Well, I mean, I think the only thing is to keep plugging away, and I think that things have definitely changed in the last few years. There's now a growing body of of clinicians and scientists. I mean, I would also plug the Society for Evidence-Based Gender Medicine, which a lot of us are involved in, and that is, bringing together more and more people, clinicians and scientists, and I'm involved with them, and so I think we just have to fight, and it's going to be kind of inch by inch. It's kind of a war of attrition, and it may take 10 years or something to roll back. But I think definitely the impetus is in the right direction.
Great. I'd like to thank Dr. Az Hakeem and Dr. Michael Biggs. And make your way through to the big panel next door.